Welcome every morning. Blah, blah. Today's first webinar for Antimicrobial Awareness Week. I think those of you who got to some of the sessions yesterday will agree that they were all incredible. I missed last one, so that's going to be my job over the weekend to watch those presentations, and to welcome to my co-presenters this morning, Joanne, Jake and Brian. I'd like to start by acknowledging the traditional owners of the lands we were on today and pay our respects to their elders past, present and emerging. So once we're in our session, we'll use a chat function to communicate amongst ourselves. For all of you who are also presenting, just close your background apps or windows that might generate sounds, and we will hopefully be able to take questions at the end of our talks. So just to introduce myself, I'm Thursky, I'm the Director of NCAS, and in relation to the talk that I'm doing today, I've had a long-standing history of working with information technology to improve antimicrobial prescribing. As you know, I'm the Director of the Guidance Group at the Royal Melbourne, and also lead the NAPS development and implementation, and you'll be hearing from some of that work with Joanne. So without further ado, I'll get going. So really what I wanted to do today was contextualise the challenges that we have in terms of using our electronic health records to undertake antimicrobial stewardship. And a core piece of that is the drive towards appropriateness. And many of us are dealing with it on an individual institution basis, but how can we start to scale up what we're doing to support a national approach and across each of those sectors? Part of that is going to be learning how to harness our electronic health records and what data we can get out to measure the impact of our interventions. And key to appropriateness, of course, and understanding why antimicrobials are used, there are some pitfalls, and I'll discuss some of those. And you'll also hear those themes through Joanne, Brian's and Jake's talk. So I'm not going to talk about the methodologies that they're using in detail, because you'll get a good feel for that when they're doing their talks. And then, of course, how do we fit into the future digital strategy in Australia? And from my perspective, it's pretty exciting, because I think what we're going to start to see are these new career pathways for clinical informatics, because it's going to be huge. The best description of what we face is actually in the UK's 5-year National Action Plan. And I often show this in talks because I just think it absolutely nails the issues. So being able to access and evaluate robust data, including the coding and recording of diagnoses, prescriptions and outcomes in both primary and secondary care, helps us understand prescribing behaviours and identify where and how practice might be changed, and improves the effectiveness of clinical decision support tools which rely on accurate coding. A lack of data at the patient level on diagnostic code and indication means it is still hard to evaluate the extent to which diagnostic tools and guidelines are being used to support those decisions. Clinical and prescribing data remain underexploited, linking and analysing data sets. And these should lead to new insights in the dynamics of resistant infections, as well as allowing better monitoring of antimicrobial use. I think this is absolutely key to what we're trying to achieve. So it really frames how I'm going to discuss this today. We should also be aware that there is actually a national digital health strategy, and it's worth, if you are working with electronic health records and in this space, to have a read of it, because the focus of the digital strategy is really about creating a seamless, safe and secure digital health service. And this brings in a whole lot of issues around data linkage, data sharing, common data models. How can we use high quality data that can be used with confidence? And this is really the fundamental issue. And how can we better use our digital health technologies to deliver health and care? This afternoon, the Centre for Digital Health Transformation is having its launch, and it's particularly exciting for those of us working in this space, because it means we will have a group of experts to collaborate with in both our research and implementation of programs. Yesterday in my plenary talk, system, and the concept of a learning health system is really bringing in a socio-technological response to improving care. And in antimicrobial stewardship, both at an individual, institutional, patient level, right through to a national level, we really need to be thinking about how we can harness all our data sources from various both external and hospital databases, which brings in issues around data definitions and interoperability. And in that first bit here, a fundamental question is, well, do we understand why that antimicrobial is used? Once we can do that, we can then better aggregate and analyse the data, and to finally start answering those questions about, is there a relationship between antimicrobial usage and appropriateness and antimicrobial resistance, and how does this relate between primary care, secondary aged care, and in animal health as well. And obviously this data, higher quality data, will enable more effective development of antimicrobial stewardship programs, clinical pathways of care, clinical decision support, etc. And finally, the holy grail of all of this, which has been very difficult, it's very difficult to find any literature on the true impact of antimicrobial stewardship. We know that it can be certainly reduce the cost of antimicrobials and reduce outcomes of care, outcomes of particular infections with appropriateness, but it's very hard to find complete cost effectiveness and the health economic evaluations, which would be amazing to be able to drive reimbursement models for quality use of medicines programs across various sectors. And then finally, if we have great data, we can have better communication strategies to our prescribers and to our patients. This is looking now from a bird's eye view within a hospital program, and all of you who are undertaking stewardship in another healthcare environment may have one or more of these, and the data from one or more of these databases are used to support your stewardship program. So there'll be legacy databases, pathology, pharmacy, usually excellent quality data, and in fact probably is a reason why internationally much of the publications around the so-called appropriateness of use is still being presented as days of therapy or defined daily doses and trends of use with some sort of assumptions around appropriateness based on volume, but we all know that we don't know that that's necessarily true, and it really is dependent on the case mix, patient type, etc., as well as local antimicrobial resistance patterns. Microbiology, and now I'm talking about not just routine bacteriology and virology, but we're now talking about genomics, which will be coming into play in terms of the data, particularly around personalised management of infections, and then various permutation combinations to support prescribing. And certainly those of us working in clinical decision support know that there are many opportunities within electronic medication systems in terms of alerts and decision support to improve prescribing. However, what we have in Australia is different systems and within those systems different builds with the variable integration of these databases and variable data access. And if I actually asked for a virtual show of hands about how difficult it is to get data out of your electronic healthcare record, I think all of you would probably put your hand up right now. It's essential in terms of hospital programs where, at least in Australia, where stewardship is very well established, that post-prescription review is part of a core antimicrobial stewardship activity. And without that, it is, I think, probably incomplete. But with that, it means we need to have meaningful data. So simply pulling out every ceftriaxone prescription in your hospital and deciding to see 10 of them, is that time effective use of your program? How can we get information aggregating data that's meaningful so that we can triage those patients that are going to be that are going to benefit most from an ID expert or stewardship review. And so this is where we need to think about opportunities to integrate these systems. And one of the challenges, at least in hospitals, is that these EMR systems are very patient-centric. They're not designed to be a systems. They do not particularly support a systems approach at a day-to-day level, and that's what AMS is all about. The Pew Trust is actually a really interesting organisation, and I follow them closely because they are one of these organisations, charitable organisations, that do really interesting quality programs across the US. And they had a very nice publication, looking at different ways that the various EMR systems are used in the US. And you know, even the smallest hospital were able to get some data to support their programs. But again, once you look through these case studies, the outcomes of them were always around volume of antimicrobial use rather than actual quality. But we do see some other publications coming out of the US looking at appropriateness of empiric therapy and things, where they've utilised their electronic healthcare records and started to build rules and algorithms to support assessments against pathogens. So there is definitely some emerging literature out there. In Australia, we're somewhat unique because to have established a national program like NAPS, which is now being used in hospitals and aged care, and we're piling it in general practice, it is somewhat unique that we've actually been able to implement a survey which is assessing appropriateness rather than compliance with guidelines. So again, if we come back to other international studies, particularly in Europe and the UK, the focus has generally been on compliance with guidelines because appropriateness has been put in the too hard basket. And that's because it is a composite measure and reflects both prescription issues and patient factors. It does take multiple data points. It does require trained auditors. It is time consuming, and the data may be in all parts of the medical record. However, we have demonstrated that not only is it feasible, but it's very well liked. And at the moment in Australia, we do it as a point prevalence or serial point prevalence survey, usually once a year, to help drive our programs. But what if we could actually undertake these sorts of surveys more frequently, real time, for example, and maybe even automated? And that's something that NCAS will be definitely looking at as we move forward. If we just think about indications and going back to that UK resistance strategy, why are antimicrobial indications so important? Well, because antimicrobial indications are required for clinical decision support. You need to understand what guideline you're looking for, and it will help with decision making. Who is on what drug and why is really part of why we do our post-prescription review. And while there are systems in place in some of the commercial EMR vendors using alerts or scores, we in Australia, I think, understand that indications are much more meaningful. And you can see even in the NAPS why indication documentation has continued to increase year on year. And that is probably reflected by the fact that it's become mandatory in many of the systems that are in place now. Having indications allows for quicker, easier collation and feedback. And finally, if we understand there is a standardised approach to indications, it would help support surveillance at a much higher level. And you'll hear about, Jake will talk about that. So NCAS has established the Universal Indications List, which is a cloud-based platform. And we use that list and update that list in the NAPS. And it was actually a several years' work to do this because it required developing a complete list of indications, and we based this on years of work with guidance and the approval program, but also understanding therapeutic guidelines, indications, and also indications where that perhaps were not we have colleagues who piloted the NAPS to add in indications, and we have a standing committee which is multidisciplinary. We update and discuss and categorise those, and importantly we have used SNOMED, which is a data set for clinical terminology, and it was common that there wasn't a SNOMED code for many indications, and a classic one was both medical and surgical prophylaxis. There were very few SNOMED codes to support that, and so we worked directly with the Australian Digital Health Agency to establish the codes. And the NAPS now, the NAPS now uses the URL, but it can also be used within any approval system or even electronic medical record to support a standardised indication. And to graphically show you what we mean by that, here we have the universal indications list for community-acquired pneumonia. And you can see that in various other systems, there might be free text that has been entered by, an EMR may allow free text entry by doctors, where they can put in all sorts of names to reflect community-acquired pneumonia. That becomes incredibly complex at the end of the year when you're doing your NAPS and you're extracting out indications for antimicrobials, and you have to wade through all the different permutations and combinations. If you actually standardise your indications list, it makes things a whole lot easier. Also, the therapeutic guidelines, we know that even within those, there are various permutations and combinations to reflect community-acquired pneumonia within the guideline itself. And again, these are some of the approval systems indications. So if you can think about standardising and why that would make your life easier, I think that's one of the reasons why we've focused on this so much. Other organisations are also starting to bring in indications. So you will be aware of the AWARE program, where they have designated particular antimicrobials as the access group or watch group or reserve group. And if you hop onto the AWARE website, you can see, sorry, touchy screen. If you hop onto the website, you can see that they've now defined appropriate first and second choice antimicrobials. And this will be particularly useful, again, because it will allow broad assessment of appropriateness in these countries that are particularly using AWARE. Also, the global PPS have a limited set of indications. Again, once you look at these, they're quite broad and nowhere near as granular as what we're collecting in Australia with regards to the NAPS program. But what about the challenges of electronic health record data? The primary desire to understand exactly what disease, or in our case, infection the patient has, is really the first essential step. Because this allows us to identify patterns of disease, target interventions, and our resources. If you simply think about the indication for antimicrobial use and you're looking through your data, which time point is correct? If we're looking at sepsis, for example, is it the presumed infection at presentation, or is it the final diagnosis at discharge? Is it something that we have to search through notes? Is it associated with a prescription? This is very variable across different systems. And once it's outside of a standardised field, then you need to think about other ways to get that data out. And you will hear about natural language processing and machine learning later in this session. Timing of antimicrobial administration, surprisingly, and big implementation in our own precinct, and it's become apparent that although the patient may have been administered the actual antimicrobial, they may not sign off the actual antimicrobial till some time later. And so getting true timing, if we're looking at sepsis, for example, as time 0, it becomes really quite difficult. And then the final issue is really misclassification of infections, which is very common, and you'll hear from that from Jake. So where do we need to go? And I guess what you've been hearing in my discussion so far is how can we think about interoperability, how can we harmonise our data, and how can we share our data across systems? And this is important because a lot of AMS up till now has really been assessing a prescription or multiple prescriptions per patient. But really what we need to be getting to is how are we managing our patient across their journey, not only from primary care, but in hospital through to secondary care. How do we understand the quality of care across their whole clinical pathway using real-world data? And be able to utilise large clinical data sets significantly reduces the potential cost of an understanding of clinical trials. And many clinical trials are moving towards a pragmatic approach, particularly in Staph aureus. Imagine if we can harness electronic healthcare records to answer some questions that we still don't know. But as you know, a lot of the data that we have to deal with is really limited. There's a lot of missing data, and much of the data has actually been designed for administrative purposes such as billing. I've reviewed a few papers now, particularly out of the US, where it actually, and the UK, where it's actually quite challenging to simply even get days of therapy in some systems, because every change in dose requires a new order in the system. So it takes quite a bit of coding to actually establish your course of therapy. And then moving into more detailed analysis of our data to understand usage and resistance becomes very complex, because we need to think about all the other treatment and outcome issues that are confounded by patient pathogen and even pharmacokinetic, pharmacodynamic factors. And then finally, we see many publications looking at appropriateness of therapy for particular pathogens, for example, but this is often done in isolation in systems without linking to surveillance data in the community and primary care prescribing data. So where to next? So now I'm going to talk about something a bit techie, and really it's around establishing common data models. And this will require bringing data into a common format. And if you're interested, we call it Odyssey. You can hop in and have a look at it. This then allows for large-scale analytics and collaborative research. And what it does, it addresses the issue about the fact that much of the data is stored in different formats, databases and models. And a classic example will be how would we do a study where we're pulling out data from Cerner and EPIC or MedChart and looking at the same question. So there's a very, very active international community working in this space, and it is happening in Australia as well. There is the ARDC program, public sector program, where many of us are involved in applications to transform our own hospital systems and map them to the common data model so that we can do broader research and not manage clinical pathways. So it's really bringing in common terminologies, vocabularies and coding schemes. So really, it's a very simple concept. All these different systems are mapped into the common data model, which allows assessment and analysis exactly the same way, and use big data. And I gave the example of the different EMR systems up above. This is a current version of the OMOP common data model, and you can see some of these things. I'm not going to go into in detail, but you can see that this is an open source framework where groups from across the world are continuing to build the data models, and maybe antimicrobial stewardship and infections in one area that Australia can contribute. Well, once you get data from large numbers of hospitals, you can actually see what's possible. And this was a paper published in August this year where they had contributors to hospitals that had the OMOP mapping to look at some clinical nappy questions around COVID. And this is really exciting. So they had, 27,000 cases, 187,000 laboratory tests, and they were able to map the trajectory of disease in patients in response to interventions, which is pretty amazing. So where does the future lie? Well, I think it is around trying to move to this data harmonisation, which is really defined as the sum of all efforts to combine data from different sources and provide users with a comparable view of data from different studies. And why is this important? Because we need to be efficient and effective in how we do, how we start to analyse and assess our own clinical practices, as well as to drive new hypotheses. And we are definitely seeing a move towards precision medicine, particularly in the cancer space, and even with genomics in now becoming much more available and cost effective. We've already talked about learning healthcare systems. And then how do we support our implementation science with effective data mapping? But this is complex and it really requires major changes in how we collect and share and link our data. And there are still very major challenges, particularly ethico-legal ones, issues around data quality, technical issues. And Australia, for example, still lacks a unique identifier. And this is, if we compare Australia to some of our Scandinavian colleagues, where they do have systems that work across primary and secondary care. There are political and sociocultural issues. All of these will need to be tackled. And I'm going to finish on one salient warning, and this is the Surgisphere scandal, which many of you will have been aware of. It was published in The Lancet, and this was really something which was a warning for all of those who are keen to look at big data and artificial intelligence in the sense that how can we answer clinical questions using big data? And this really highlighted major issues around data quality, data access, and governance. And those of us who are working in this space need to consider very carefully the ethico-legal issues and data quality and data safety when we're working with data out of our electronic records. And so I'll finish there and open up for questions. So you can post questions on the Q&A. Okay, any questions? All right. So Arjun, are we right to move on?
Sure, Kaz. We've had a couple of emails already asking if this presentation can be shared in hospitals with, for education purposes. So of course it's being recorded, and yeah, you can use it after.
Yes, yes. I have gone a little highbrow this morning, but I guess it's, Sajal has asked what's a starting point for doing the OMOP. From speaking from the Melbourne perspective, this is being driven through Doug Boyle with the Centre for Digital Transformation, and there are many groups that are looking to that at a higher level. I think this is going to be part of the National Digital Strategy, and we know that it's sort of happening already with Cerner. So it really requires partnering with the groups at a university or other level. So I don't know the complete answer there, Sajal, but I guess there are groups that are working, and there is a national community of working towards it. James, morning James, has asked about harmonisation. So it's been the goal of the OE for many years. How likely do you think we harmonise records across hospitals in Melbourne versus across Australia versus Victoria and versus nationally? There are many impediments. So even at the moment, we know that even taking New South Wales, for example, where they have Cerner, MedChart and perhaps some other EMRs, even within Cerner, there are multiple different builds. I think 7. Epic has come into the Parkville precinct, and even right now, even within our own precinct, we're really, really struggling with it. And part of the reason is that as you implement it's very expensive to implement these systems, and from my own personal experience in the implementation in Peter Mac and Royal Melbourne, I'm not sure there was enough thought about how to get the data in, because what we're struggling with is that rubbish in, rubbish out concept. Clinicians are very busy. You can't expect them to, write things in a standardised way. We need to use these systems to drive the way we collect the data as part of our routine clinical practice. AMS is a classic example where we have to collate a whole lot of data to make decisions, but those systems aren't the ones that do that. So as we build our own post-prescription review and data collection, many of our listeners this morning hold on to those very tightly because we know how much work it is to do. So there are major ethico-legal challenges. We already know some of the discussion around the My Health record. There needs to be public trust if we're going to be using data sharing. And then there are a whole lot of data governance ethics approaches which I don't think are really there yet. So I think there's massive rewards to be able to do that, but maybe we need to take a stepwise approach. All right. So thanks everyone. So the next speaker this morning, again, probably doesn't need a huge, I think many of you will know Joanne. She's a remarkable person that we're very happy to collaborate with. She's Associate Professor, Academic General Practitioner with the Department of General Practice. She leads a data-driven quality improvement theme which conducts innovative research into the development and implementation of technology to inform decision-making in general practice, and the use of data to describe and improve general practice activity with a focus on chronic disease management and antimicrobial stewardship. So welcome, Joanne.
Thanks very much, Kaz, and thanks as well for the opportunity to speak today. Can I just check that you can see my screen okay?
Yep, all good.
Oh, okay, fantastic. So what I'd like to do today is share with you all our experiences from implementing Guidance GP, which is a pilot that we've just completed of an antimicrobial stewardship quality improvement activity in general practice. As I go along, we'll touch a little bit from a really quite practical sense about some of the issues that Kaz has just touched on with her talk. So you've laid the groundwork very well, Kaz. But in addition to how we extract and use data from general practice electronic medical records, I also want to talk about the importance of qualitative and other data to help us inform the implementation of programs that use this data, because really that's going to be key to their success moving forward. So I think it's really important to start with some context. So in Australia, I'm sure everybody in the meeting is aware that we've got relatively high levels of antimicrobial prescribing. So back in 2017, our data from the Pharmaceutical Benefit Scheme suggested that 41.5% of Australians had at least one antimicrobial agent dispensed that year. And a higher proportion of these are being prescribed for conditions that should not typically require antimicrobial therapy, such as upper respiratory tract infections. I think it's very telling and a bit surprising, or it certainly was to me when I first read about this, was that the volume of antimicrobial use per capita in Australia is more than twofold that of comparable countries in Europe and Canada. So today, when I talk about antimicrobial stewardship programs, I'm defining that as coordinated interventions to improve and measure the appropriate use of antimicrobial agents. Now, as Kaz has presented and her NAPS group have done obviously a lot of work in this area, those programs have been effective in hospitals in helping to inform people about what prescribing is happening and helping to optimise antimicrobial prescribing, and of course is also part of accreditation. So what's happening though in primary care? Well, the National Antimicrobial Resistance Strategy 2020 and beyond has identified the need to implement antimicrobial stewardship strategies in primary care. But what we have at the moment is more short-term targeted actions. Now, these have been employed to reduce antimicrobial overuse with some benefit, things like NPS audits and government nudge letters. But these are not continuous, they're not ongoing, they're focused on volume and they haven't focused on appropriateness. That's something that we've found is very important to GPs when they're thinking about their prescribing. So an ongoing activity that's acceptable to general practice, we think is important to optimise antimicrobial prescribing in our setting, which is where the majority of antimicrobial prescribing in humans occurs. And so we commenced a program of work back in 2017, a collaboration between the Department of General Practice at the University of Melbourne and NCAS. Starting really right at the beginning, just to understand how GPs were using their electronic medical records and guidelines to make decisions. We progressed to an audit that in some ways was similar to what was being conducted in hospitals in terms of we had an antimicrobial stewardship pharmacist who went through the entire GP electronic medical record and did an audit. And GPs really liked the results that they were receiving back from that audit. They found it really helpful, particularly when it was combined with the feedback webinar. But the reality is that that could not be something that was able to be delivered at scale. So we moved on to look at co-design, how to integrate guidelines with electronic medical record, and we looked at how that could be used in a consultation with a simulation study. And we took all of that program of work and we used it to inform the development of Guidance GP, which really we see as a program that's been co-designed with our general practice end users. So over the last 12, 18 months, we've been conducting the Guidance GP program. And so our objective was to evaluate the program for antimicrobial prescribing in general practice, consisting of audit and feedback and a clinical decision support tool which aimed to facilitate access to therapeutic guidelines. Today, I'm going to mostly focus on that audit and feedback component and how we did that. So Guidance GP consists of the key elements that you can see listed on the left side of the screen here. And GPs went through this program, which occurred over about a 12-month period, and completion of which entitled them to some quality improvement, continuing professional development points. And we had 41 GPs participating in 3 general practices in metropolitan Melbourne. And there was a range of between 5 and 21 GPs per practice, and they were all using the same electronic medical record system. So what we did is we created a data extraction tool, and we extracted key data from the electronic medical record over a 2-week audit period each time that an antimicrobial was prescribed. And the types of information that we were pulling out included things like age, allergies, medical history, recent pathology results, investigations that were ordered during the consultation, gender, if the person identified as an Aboriginal and or Torres Strait Islander, and of course, prescription details. And we were really taking a data minimisation approach which was based on our previous experience in conducting the manual audit. The other thing that we did was that if a reason for prescription was not recorded at the time of prescribing at the consultation, then there was a pop-up tool that came up, and it requested the GP to enter a reason for prescription from a curated list called the Universal Indication List that Kaz just introduced you to, which was developed by the guidance group. So we conducted the initial data collection back in November last year. And as I said, we chose this over the manual audit of files as our previous pilot had showed it was time consuming and expensive. And we don't actually have the workforce in general practice to be able to conduct such a detailed audit. The prescriptions were then reviewed by an antimicrobial stewardship pharmacist who then had a case discussion in terms of prescriptions where the either compliance or the appropriateness was unclear or difficult to determine. And so, of course, it could be that whilst a prescription was not compliant with therapeutic guidelines, it might have been appropriate to treat the infection. So on your screen now, you can see a little bit of a snapshot of the written feedback reports that were provided to each practice. And following the provision of these feedback reports, the overall results were discussed at a webinar. So what you can see is we provided feedback about the most common indications, most commonly prescribed antibiotics, compliance with guidelines, both in the practice and compared to practices overall, the most common indications, and then some snapshots about what was performed really well and different things that might be targeted for action moving forward. So we also made therapeutic guideline subscriptions available to all participating GPs, and they also received quality improvement support from the North West Melbourne Primary Health Network. And we completed our follow-up data collection audit back in a couple of months ago in September this year. So our research is really focusing on implementation. Could we use extracted data to make assessments, including undertaking a validation audit? And were the reports and program acceptable? What changes did GPs identify that they could make as a result of the program and the data that had been presented back to them? So it was really about implementation, not about effectiveness at this point. However, to give you a little bit of an indication of what we found, during our 2-week audit period last year, we had 231 antimicrobial prescriptions that we extracted and were able to assess. And this year, that reduced significantly down to 73 over the same audit period. And I think what that's demonstrating is the impact of COVID, both on general practice presentations and also infectious conditions. However, what remained consistent was the proportion of prescriptions that were compliant with therapeutic guidelines, which sat at just over a third, and the proportion of prescriptions that were adjudicated as appropriate, which sat on about 2/3. And not surprisingly, you can see that the most common indications that we found were things for like the skin and soft tissue, ear, nose and throat, and respiratory tract infections. It was really important for us to understand if using the extracted data to make these assessments was, I guess, accurate enough or reflective of what we would have undertaken had we had access to the full electronic medical record. And so we did conduct an in-practice audit of the initial 231 prescriptions that were assessed in the baseline for our study, and we were able to show a kappa of greater than 0.2 for both compliance and appropriateness, which suggests a substantial inter-rater reliability, and therefore that using extracted data is going to be reliable enough to be able to do these and undertake these assessments. But of course, it doesn't matter if we want to collect data from general practice if it's not acceptable and GPs don't want to provide it and they're not going to necessarily respond to that data, there's lots of different factors that are going to impact on their participation and willingness to participate. So we undertook 3 focus groups, 1 focus group with each of our participating general practices. And then we analysed our data using a theory called the Clinician Performance Feedback Intervention Theory, which was a theory that was developed by one of our colleagues, an academic GP health informatician, Ben Brown from the University of Manchester. And what you can see on your screen here, the items in green are the key elements in the theory that we focused on for our analysis. And the blue boxes are the key themes that arose from the data. So in terms of goals, well, GPs viewed antimicrobial stewardship as important. The challenge was some of the issues around control over prescribing. So this varied from some GPs being very adamant that they didn't want to be told what to prescribe by guidelines or by our program, to the other extent that GPs felt that they didn't necessarily have 100% control over their prescribing because patient views and beliefs also had an impact. Guidelines were seen to be important, but GPs felt that they didn't always take into account the patient journey and experience. So using those guidelines to look at compliance and appropriateness was challenging. And there was also a tension about the goal of this study. Was this a program to assist GPs to optimise prescribing, or was it a tool that could be used against practices or to show that general practice wasn't performing? In terms of the data collection and analysis itself, obviously the quality of recording in the electronic medical record could impact on the ability for us to undertake these compliance and appropriateness assessments, and GPs were very aware of that. They had concerns about the accuracy of assessments given the types of ways that they entered data. But they also said that the context in which those decisions were made was also important, and this wasn't something that they felt could necessarily be adequately done by using data just from the electronic medical record. In terms of feedback, benchmarking was seen as very helpful so that practices could compare their performance to others. But there was also interest in individual level feedback, which was beyond the scope for this study, but something that we're certainly interested in doing in the future. Finally, knowledge and skills of health professionals and their attitude to receiving feedback are obviously important health professional characteristics. And practice adaptability and cost, both in terms of money and time, were also important factors impacting on our ability to implement this program. And so I think a key thing that I wanted to reflect on with you today is around data. General practices, there's over 7,000 of them around the country. They're primarily small businesses, and they're the ones that can make decisions about whether to share their data or not and with whom. And so it's really interesting to consider the perceptions of our participating GPs on whether data was a weapon or it was a tool that could be used to help them in their practice. So we've pulled out a few quotes here just to illustrate these points because it's really important from an implementation perspective. So in terms of, this data on antimicrobial prescribing being used as a weapon, well, this GP said, well, I've got concerns. My biggest concern about this data and what's going to happen and be used with our data, because I have a very strong sense that the final destination for this stuff is going to be a KPI for funding practices. There's sort of sharks circling all around us. And for accreditation or to get your practice incentive payment or whatever, if you have to demonstrate that you've got 85% compliance with your antibiotic stewardship. The other thing that's an issue that has to be addressed is trust in the data and its analysis. So you can see that this GP said, well, I think I was surprised initially when I saw that report of how much inappropriate prescribing we had, but I'm hopeful that some of that's data collection. So in other words, the way that we did the analysis rather than their actual practice. But then it's also a reminder that things do change in therapeutic guidelines. We kind of get into ruts and you kind of just have to take this is what you prescribe for that. The other thing is that the data has to be useful and provided in a way that's seen as helpful to build practice and not threatening. So this GP said in terms of our reports, well, I think that's more helpful than that random letter that we all got or some of us got. But it seems like a bullying, threatening kind of letter, whereas this actual data is more useful. And the other point, which, as I mentioned back in the beginning of this presentation, was about the ability to get data in a continual fashion, not just once off. So this GP said it's got to be about keeping antibiotic stewardship sort of front of mind. It's about keeping it salient. So any way that I can be reminded throughout the year, if it's group-based or it's a pop-up on best practice, or if it's part of the induction when the new doctor starts, whatever it might be, it's just about sort of constant reminders as opposed to, yes, we're done now and you don't have to think about it again. It's just keeping it in your head. So what was the impact of this data and changes in practices that the GPs indicated that they'd undertake? Well, that came under three main themes. The first was use of guidelines. So GPs did say that they intended to bookmark guidelines to provide better access to them, that they would be accessing them more regularly, that they would be distributing information from therapeutic guidelines to GPs within their practices. And so that was some important changes. In terms of changes in prescribing, this included things like understanding that a pathology result indicating that a certain antibiotic can be prescribed doesn't necessarily mean it's the most appropriate antibiotic to use, that they would use stricter use of dates and limiting medication quantities and use more delayed prescribing. And thirdly, in regards to patient education and resources, they said that they'd provide patient education for conditions that don't require antibiotics, that they would put posters up around in their clinic waiting rooms for patients to visualise and read about appropriate antibiotic prescribing and how that can be helpful in avoiding antibiotic resistance. And that they would also look at shared decision making and the use of patient information sheets. So in conclusion, Guidance GP was seen as an acceptable program and antimicrobial stewardship was seen to be an important focus for general practice. Costs associated with guideline access and the workload associated with quality improvement programs, particularly for practice managers, and of course the practice more broadly, were potential barriers to ongoing participation. And so the streamlining of continuous professional development requirements and increasing confidence in data analysis and clarifying how the data is going to be used by the practice and other parties is going to be very important in facilitating future involvement in these kinds of programs. So what are our next steps? Well, we've been very grateful to receive 2 rounds of funding from the RACGP Therapeutic Guidelines Grant to undertake our program of work to get it to this point. And we're exploring ongoing funding opportunities to look at how we can scale this. And an important component, which I'm interested to hear from our next speaker, is about using machine learning to optimise prescription assessment and really be able to further scale that up. And some preliminary work has already been done on our GP electronic medical record data using decision trees, showing that this is a feasible way for us to be able to move forward. I think that we need to look at how we can streamline IT as much as possible for practices and practice managers, as that's going to be key to get them to be able to continue participating in programs like this. And we'll be looking at optimising the methodology that we use for feedback sessions moving forward. So I might just finish up there. I'd of course like to thank or acknowledge our different funders. I'd also of course like to really acknowledge all of the GPs and general practice staff more broadly that have participated in the program to date and really helped us continue to grow this program of work. And I think a really key thing for me going through this process and working with the team at NCAS has really been that general practice does need more attention in this area, and that it's great that we've been able to do this research to this point, but I think that's really important to acknowledge if this really is a key priority area, you know, for health and for Australia, then general practice can't be ignored. It needs to be part of that part of that story moving forward. Thanks very much.
The dog really liked your presentation, Joanne.
Thanks.
Okay, we'll open it up for oh no, my parrot's going now. So we'll open up for questions. So we have one from Leslie Halls, who of course has recently finished her PhD out at Monash. So great work and really interesting. I'm not a GP, but if an ETG non-compliant prescription can be appropriate, does this mean ETG needs revision for the type of patient seen in general practice? Is the measure of compliance appropriate, especially if it's going to be used as a weapon?
Well, I think the first thing that I would say is that GPs are concerned about this data being used as a weapon, but I think that we need to be very clear that that's not what we're trying to do. From our perspective, this is about quality improvement and optimising the care that's usually very, very good quality care in general practice. So even though I've referred to data as a weapon, I think part of what we need to do is to remove that, actually. In terms of therapeutic guidelines, I actually been really impressed working with therapeutic guidelines as part of this program over the last few years, and the efforts that they're really going to try to optimise the guidelines for use in general practice, including providing some additional summary sheets, and actually being really interested in the results of this research so that it can continue to tailor the guidelines and how they're communicated to GPs over time. And so I think that that's a really important thing to keep in mind. I think both compliance and appropriateness are both important, but our strong feedback is that, appropriateness is something that is a lot more meaningful to GPs than compliance alone. And of course, there's many different guidelines, and compliance with one might not necessarily equate to compliance with another. And that's another challenge that we've got.
I'd also like to pipe in as well, because I think what's becoming very clear for guideline developers now that there is an expectation that guidelines are actually implementable. And there is a framework now. Courtney Arana looked at the ETG surgical prophylaxis guidelines, and that GLIA framework is available on the NHMRC website, but it is actually really important moving forward how we develop those guidelines. And that's one of the things that we're going to be doing, collaborating with Jill Francis at the University of Melbourne, understanding what are the aspects of a guideline. I think I touched on it yesterday in my talk, that make it very clear as to who does what and why and when in a guideline. And the ETG obviously simply cannot expand to cover all those issues in their book. It would be an encyclopedia. So we need to be thinking about how we actually implement effectively in the appropriate way. James Gilkison again. How important is the role of the practice manager in gaining buy-in to the GP guidance program? It's an easy question to answer.
3,000,000%. Look, we haven't presented it here today because we're still going through some of the data, but my colleague Ruby Beason has actually interviewed, we changed our ethics because we recognised that they played a pivotal role, and we've gone back and specifically interviewed the practice managers at each of the practices to make sure that we gain their perspective. They were pivotal in the practices agreeing to participate, doing the IT installation, scheduling and facilitating quality improvement activities. So to be honest, without a proactive practice manager, really, it's not going to happen. I think that's a pretty fair summary. Yeah.
James, I've made you live. Did you want to comment on what the comparable issue would be in the companion vet practices? If you can, I think you're unmuted, so you can talk if you want to. You don't have to if you don't want to. There's another question from Jay Gomboso. So great presentation. Maybe one way to deal with privacy issues is to de-identify data in a similar way a Barris does when they do their farm surveys or ABS do their census. Downside is not being able to provide individual results to GPs for rather collated results.
Thanks very much for that feedback. We already use for a lot of our data extraction work, privacy controls, hashing of identifiers, anonymisation, applying those things before the data leaves the practice and a lot of the work that we've been doing. I think that, this is a rapidly changing field. There's lots of discussion around, patient consent versus the use of, extraction of this data for quality improvement and health services research and the like. And so it's a moving feast. I think part of this moving forward is probably going to be about some way of aggregating data to some extent, even before the data leaves the practice. But there are ways of anonymising the data and then re-identifying it in the practice. And my colleague Dougie Boyles developed a tool that facilitates that we've been also using in other studies as well.
Fantastic. Okay, thanks, Joanne. Another brilliant presentation. So now we're going to be moving, we're just going to be jumping to Jake Valentine, who I've also very happy to introduce. I, of course, work with Jake across the Peter Mac, where he's doing a PhD with the National Centre for Infections in Cancer. And he's a PhD fellow. He graduated with a Bachelor of Biomedical Science with honours at Monash and the Central Clinical School at Alfred Health in 2017. And he's been actively engaged as an undergraduate research assistant at the Monash Biomedicine Discovery Institute in the field of ID and microbiology. He is working now with us at Peter Mac, looking at utility of administrative and clinical data to assist with surveillance of infections, particularly in the cancer space. And I actually asked him to talk today because I can't think of a better person to discuss the challenges that we face with coding data when we're trying to undertake surveillance. There are definitely limitations, but what Jake has demonstrated is some truly great opportunities. And I think it's always important for all of you, those of you interested, when you're looking at measuring outcomes of patients and looking at mortality and outcome data, you will be interacting with this sort of information. It's not always easy to work with, but hopefully Jake will lift the veil a bit, and you can learn about how you can use that. So thank you very much, Jake, and off you go.
Thanks, Kaz. Thanks for the kind introduction, Kaz. So as Kaz mentioned, my name's Jake Valentine. I'm a third-year PhD candidate here at the National Centre for Infections in Cancer, based at the Peter Mac and the University of Melbourne. So the title of my talk today is the use of administrative data to support infection surveillance, but also health services research more broadly. Now, to do that, I'll be focusing primarily on some of the limitations, but also on some of the opportunities for admin data in those roles, in the context of not only the broader literature, but also my own PhD findings that have sort of come to fruition over the last 3 years. So to get the ball rolling, I'll just start by looking at the overall role, I guess, of administrative data for those purposes. So if you look at the very definition of administrative data, which is up on the top left-hand corner here, it is information collected for the purpose of registration, transaction, and record keeping associated with the delivery of a service. Now, the key point to make there is that this doesn't have to be healthcare per se. It can actually be any industry. It can be commerce, it can be accounting, just so long as you're keeping track routinely and longitudinally of any observation that you may be interested in. Now, if you look at the definition of health services research, or HSR, it examines the access to the use, cost, quality, delivery, organisation, financing, and outcomes of healthcare services. So it's certainly in my mind, and this is what the literature is telling us, is that administrative data really underpins it's really the foundation of health services research in terms of measuring, things like certain health interventions or looking at the effectiveness of certain programs. Administrative data, by its very definition, can actually be quite an attractive form of data or information to measure health services research. Now, what I've done is I've actually sort of drawn up a little schematic to actually highlight that administrative data isn't just one type of data per se. It actually consists of a series of different types of information. Now, and this is in the healthcare setting, this is certainly the case. So the purple circles are more your epidemiological kinds of data, whereas the ones I've highlighted in pink are very useful for health economic analyses. Now, in terms of, the more epidemiological associated admin data, we can do a lot of things with it. We can do, particularly for disease surveillance, in terms of monitoring patient safety, for example, the hospital-acquired complications, or the HACs for short. We'll be talking about that in greater depth later in the talk. It's very, very useful for disease epidemiology, but also disease classification, which is incredibly important for surveillance. Now, starting at the top, you can see here, and I'm sure many of you have heard of this, is ICD-10. This is your classic admin data. I think when people think administrative data, this is what they go to. If you're not familiar with what they are, you will be in the next slide. I will demystify that for you. We've also got things like condition onset flags, which are very useful sources of information to determine time of condition onset during a hospitalization. We've got ACHI procedural codes, which are effectively the same thing as ICD-10, but rather than codifying a diagnosis, we're effectively codifying an in-hospital procedure, be that a surgical intervention or be that any procedure that would be done in the hospital environment. Then sort of, transitioning into the health economic space, we've got things like DRG codes or MDC codes. They're slightly different, but both are very similar in the sense that they are more or less an amalgamation of a combination of ICD-10 plus or minus ACHI into a single code for that hospitalization to describe the overall cost burden of that particular episode of care. We've got clinical costing data itself, once again, extremely useful for health economic analyses. You can look at things like total and bucket costs and attributable costs of disease, particularly for infection. On the flip side of that, we've also got WEIS, if you're a Victorian, and NWA if you come from other states and territories, in terms of how much hospitals claim in hospital remuneration from state and Commonwealth governments, which I think is a very, very, very important part of health services research, because in theory, you'd want, the amount you spend in healthcare expenditure, you want that to be balanced in terms of how much you would therefore claim back from governments, both national, but also state and territory. And hence it's very important for activity-based funding analyses, but also from a health policy perspective. And a lot of my research in my PhD has actually been looking at certain health policies, the sustainability and the equitability of particular policies in a cancer case mix in terms of infections. And I think this is a very important part of HSR, because I think health policy does underpin a lot of the work that we do, particularly in the antimicrobial space, how we guide and treat patients. So I think it's very, very quite important. Now, in this presentation, in my vision, and certainly in my PhD, I don't want to look at these individual data points as alone kind of thing. My vision is to use all of these data in harmony, to use them in tandem, because I think that is where you can really unpack a lot of the value of administrative data. Now, ICD-10, by definition, is a monohierarchical codified medical lexicon or ontology. So basically, it really just codifies disease into a series of codes. So there are literally tens upon thousands of them. It's a coding system endorsed by the World Health Organization, so it is really, really quite large and comprehensive right across the globe, not just here in Australia. But each country will have their own adaptation to it. So in Australia, we have the Australian modified, hence the name, hence the AM, and different countries will have their own adaptation to the coding system, but they're not really that substantive in the broader sense. Now, when you want to understand ICD-10, there are two important components you need to understand. The first of which is the code itself. Now, what you're looking at here is just your classic anatomy of a code. Take home from that is it really just consists of a series of numbers and letters. And the second component there is the condition onset flag, which I alluded to earlier, or the COF for short. Now, the take home from that is that it's typically a binary indicator. It just really helps us determine, was this code, was it a diagnosis that was present at the time of hospital admission, or did it occur somewhere during in-hospital stay? So it can actually help us distinguish, for example, between a hospital-acquired infection versus a non-hospital-acquired infection or community-acquired infection. And of course, relevant to Antimicrobial Awareness Week are the superbugs. And good news is that, yes, you can actually use ICD-10 to measure or longitudinally measure the rates of MDRO infections. So there are codes for resistance to 22 different types of antimicrobials, including codes for resistance to multiple antimicrobials, if indeed you have a bug that happens to be, resistant to a lot of drugs. Now, to give some broader context to how this process actually works and to help you identify an MDRO infection in your administrative data sets, if indeed you come across one, is the first thing is to identify the pathogen. So I think, your classic example might be MRSA infection, for instance. So in this instance, you would look for a Staph aureus code, which is it's a code on its own right. That would, in this case, be an A code, an A chapter code. Second, you would therefore find or you determine using the cough indicators whether this was a hospital-acquired or non-hospital-acquired MRSA infection. And I think the third most important point to make with this is that you would identify the relevant Z chapter code. So it's the Z codes which actually denote resistance to antimicrobials. Okay, then there are 22 of them. So in the case of MRSA, it would be the methicillin resistant code. And therefore, based on all that, you would have MRSA infection. Now, to give some further context behind that and some credibility, I suppose, is that the Commission actually used this coding system in their HAC list or their hospital-acquired complication list, and they've been doing that formally since 2018, since the HAC policy has been in play. So it's certainly used nationally. It's endorsed by a lot of national bodies, but it's also used even in the States as well and other countries across the world. Now, in this slide, I just want to highlight some of the pros and cons of using particularly ICD-10 for infection surveillance, but also for health services research more broadly. The first point to make is that, yes, this is your classical it's your classic big data. All right, when you think big data, this is probably one of those types of data that you would think of because it's just so huge. It's used right across the world. It's collected, theoretically in nearly every hospital in the country for administrative and billing purposes. So it's quite large and comprehensive. In terms of their advantages, I suppose, first one, it's standardized. The fact that it's codified, it's standardized, means it's an extremely attractive form of data to use to compare burden of illness, to compare incidence, to compare prevalence across jurisdictions and across healthcare facilities. It makes it quite useful for that, from that perspective. From an epidemiological standpoint, there's low attrition and sampling bias, which is very, very useful. It's a very feasible form of data to collect. They're readily available electronically, particularly at the hospital level. They're routinely collected and archived. And they're also periodically updated, I think every 2 years, I think it is, in accordance with Australian coding standards. So it's not an old school data. It's actually quite a useful source of information from that point of view. But I think that some of the disadvantages are certainly worth considering. And this is really, really important points to make, particularly if you want to develop a surveillance system predicated solely on the use of ICD-10. The first point there is that the accuracy of the codes denoting a particular disease, whether it's infection or non-infection, is almost completely contingent on the quality, the legibility, the depth of medical record abstraction, or how well something is documented in the medical chart. And on the flip side of that is also not just how well something's documented, but also how well it's interpreted by the clinical coder. Because at the end of the day, a clinical coder is a human being, and human beings do make errors from time to time. So we need to ensure that on both sides of the spectrum, that not only are we coding, or that are we documenting something as accurately as we possibly can, but a clinical coder can actually fully understand what they're interpreting or translating into those codes. Second point is that there's high desirability and information bias, and that has been noted particularly in the United States, not so much here in Australia, but certainly from overseas. And another very important point here is that there's actually variable sensitivity, specificity, and positive and negative predicted values for the codes. And that really changes quite significantly according to unique infections. Some are more harder to code than others. But to give some context behind this, if you're thinking of developing a surveillance system which uses solely uses ICD-10, and if you have a low PPV or you have a low sensitivity, you actually do run the risk of inappropriate antimicrobial therapy in false positive cases, where we have a code, but it actually isn't an infection. And on the flip side, you actually risk delayed therapy or no therapy at all in false negative cases where we didn't have a code for infection, but in actual fact, that patient did have an infection. So there are some serious challenges and consequences of using codes solely for that purpose. Another one is that it only applies to inpatient admissions. So it's almost redundant from an outpatient setting, unfortunately. And this is kind of the elephant in the room a lot of the time, is that there's a time lag. for something to be coded. Okay, so this can be up to a month. It's on average, it's a month. It can be less. It can even be more than a month for an infection from the time it's documented until the time it's coded. So for things like real-time surveillance, doesn't really work very well for obvious reasons. And if you're thinking of wanting to administer prompt administration of antimicrobial therapy, and you're waiting for a code, you could be waiting for quite a long time, and that does not make for good medicine for obvious reasons. Now, this is probably one of the more important slides of my talk, because I get asked this question a lot, and it's how feasible, Jake, is it to actually use ICD-10 for infection surveillance? And is it something we should be doing? Well, my response is always, well, it actually depends. Okay, it actually depends on the scope of your surveillance system. If you want to develop a surveillance system at your hospital or in your jurisdiction, these are the things you need to consider. First of all, and I'm going to speak in general terms here, I don't really have the time to go into the nitty gritty, but when it comes to infection surveillance, we can think of it in two groups. We can have retrospective and we can have prospective surveillance. Now, retrospective surveillance does sound a little bit counterintuitive, because you'd think surveillance, it's more real time into the future, but there is actually such a thing. Now, in retrospective surveillance, it's really by definition just going back in time in historic data to identify infection. Right? Now, we can do this manually, or we can do this electronically. Now, manual retrospective surveillance is something I'm sure many of you can attest to, which is your classic chart reviews, including myself. Now, these are very time-consuming, onerous things, right? And they're very costly. So they're not very sustainable or feasible from that point of view, and they're also error-prone as well. But electronic retrospective surveillance is much the same thing, but rather than manually using, historic, hard copy records, what you're actually doing is you're actually using things like EMR data, you're using electronic data and certain computer models to model that historic data and go back in time to identify those cases of infection. So it's somewhat expedited from that point of view. And the end game, of course, is to have that clinical decision support system, because at the end of the day, that's why we have infection surveillance, to monitor quality improvement, but also to identify infection and treat infection. Now, from a retrospective sense, it probably sounds once again a little bit counterintuitive, but by its very nature, that's what we intend to do. But prospective surveillance is what we predominantly do now, I think, from a state and territory perspective as well. Now, we can do this manually or electronically, which of course is finding infection in real time, or from here on out. Now, believe it or not, we actually do this quite a lot manually. Okay, so things like particularly at the state level. So we do manual surveillance for SAB, CDI, MRSA, VRE, SSIs, CLABSI, and the list just goes on at a state level. And we do this here in Victoria, and I'm sure we do it in other states and territories as well. Now, this basically requires infection prevention staff to go through medical charts, to go through a whole series of data manually to identify infection, which is an extremely costly and tedious process. So where my PhD is going, and certainly where the literature is going, is how do we then expedite, well, how do we go from manual to electronic means to streamline that whole process? And in terms of electronic prospective surveillance, we can think of it into two groups. We have semi-automated and we have fully automated. Now, in a semi-automated electronic prospective surveillance system, what we are doing here is you're basically collecting a whole series of different data, right? You're collecting administrative, you collect your pharmacy, you collect your pathology, microbiology, et cetera, et cetera. You pull all that data together, and then you do some predictive modeling on that. Now, once again, that is a whole presentation in its own right, but you would find the most appropriate model, you would model those data, and in theory, what you get is a prediction at the end of the day. So based on those trends in the data, you'll say, right, here we have an X% risk of infection. You would then set a threshold. So you say, right, I'm interested in infections that are greater than 80% risk. And where we have those greater than 80% risk of infections, we would manually go through each of those cases and tick them off. Yes, that's infection. Yes, that's infection. No, it's not. So the computer's doing most of the work for us, but then we sort of semi-automate that manually at the end of the day. Now, in the fully automated surveillance system, it's basically the same thing. You're modeling the same data. The only thing is that you're kind of circumventing that whole manual process. Okay, so you're kind of fully trusting the computer. So when the computer gives you a higher probability for infection, you trust that and you treat accordingly. So therefore, at the end of the day, it's still a clinical decision support system. You're using the model, you're using the surveillance system to guide your antimicrobial therapy. So obviously the big question now is, well, where does ICD-10 actually fit in all of this? Well, I probably hate to say it, but I honestly, from what I've read in the literature, from my own research, ICD-10 does not do very well for prospective surveillance for the most obvious of reasons, that there is a time lag. And that's what I mentioned before. The fact that there is a time lag, whether it's a month, whether it's a week, doesn't make for good real-time surveillance, because, you know, in a real-time surveillance system, you want to identify an infection as soon as possible and as reliably and as robust as possible. However, and this is where some of my research is now leaning towards, is, well, how can we still leverage this data? Because after all, it is a very feasible, it's a very unique, attractive form of data to use. Now, in my vision is that ICD-10 could in fact be the bridge between retrospective and prospective surveillance. And what I mean by that is that we could use historically coded data in tandem with other historic data, so, you know, pharmacy, pathology, use it all together to predict future onset of infection. So we're still using retrospective data collections, but we're using that and then modeling that to then predict, right, so if you have a hospitalization in January, we use that January data to predict infection in February, kind of thing. So this is where we could see some potential use of ICD-10 from a surveillance perspective. But the take home here is that ICD-10 just does not work very well for real-time prospective surveillance. Now, I'm going to talk about the limitations of admin data using 3 case studies from my research, which is, we'll look at sepsis, we'll look at IFI, invasive fungal infection, and we'll also look at the HAC policy as well from a policy perspective. So the first 2 case studies is sepsis and IFI. So one of the earlier questions I asked myself in my PhD was, well, what is the quality of ICD-10 for retrospective case detection of sepsis and IFI in very high-risk patients with cancer? So just before I start, as I'm sure many of you are aware, cancer patients are extremely susceptible to a whole broad range of infections. So it's important that we have a very robust surveillance system in place to identify them. So what I've done here is I collected a gold, look at sepsis to start off with on the left-hand side. Where's my mouse gone? Here it is. I've collected some gold standard clinical data from the Peter Mac sepsis pathway, which Karin Thursky has championed over the years. And having got those data, I then linked them with their corresponding codes. And I said, right, of all the gold standard diagnosed cases of sepsis, what proportion of those actually were assigned a sepsis code? And I grouped that into 2 groups, the ICU admitted patients and the non-ICU admitted patients. And as you can see here, we've got about a 74% concordance rate or a sensitivity in the ICU admitted patients and a 59% in the non-ICU admitted patients. So it doesn't, it's not a very promising result, because remember, in theory, this should be 100%, because every time, you know, when you have an infection, it should be coded. Now, I then applied that pretty much the exact same study methodology. I collected some gold standard invasive fungal infection data, and then I linked that with its corresponding coding data. Now, this study was recently published in PLOS One, if you're interested. But what I've done here is I looked at the sensitivity, the positive predicted value, and the F1 score, which is effectively just the harmonic mean between sensitivity and PPV of the IFI codes in a pediatric cancer setting. And as you can see, the overall pooled average is actually 60% right across the board, which doesn't excite me very much, but it's not dismal, but it's certainly not very exciting. It's quite a mediocre result. But the interesting part here, and this is where could be some potential for ICD-10 from an epidemiological standpoint in terms of looking at rates over time reliably, could be, well, if you look at the sensitivity of the codes to detect yeast infections versus mold, it's almost double that. So 83% versus 42%. So what this study is telling us is that there could be some potential in using the codes to track rates over time. But once again, if you're looking at a surveillance system, once again, it depends. What is the scope of your surveillance system as a retrospective or prospective? Now, the third case study, which I'll touch on, is the HAC policy. So the HAC stands for hospital-acquired complication. Now, these can include infectious and non-infectious HACs. There's a broad range of them. To give some history behind it, so in 2017-18, HACs actually cost $4.1 billion in healthcare expenditure in terms of managing, treating, and preventing them right across the country. That is 8.9% of the federal healthcare budget. That is a huge chunk on something which, by definition, and I stress by definition, is preventable. I know that some HACs are more or less preventable than others, but you know, so that's $4.1 billion, which could be better spent in our healthcare system elsewhere. So clearly something has to be done about it to prevent them from occurring, okay? So the Commonwealth Government, in consultation with state and territory governments, sat down with the Independent Hospital Pricing Authority, the IPA, as well as the Commission, to develop a new model. in order to track them, to track hacks, and to prevent them from occurring. Now, the way in which they went about doing this is to actually use the ICD-10 codes with their corresponding cough flags to identify a hack. Now, this has been in place since July 2018, but what the policy is actually doing is I speak in general terms here, but it's using every time a code denoting a particular hack gets reported to a government, that hospital or those groups of hospitals will actually have a percentage of their hospital remuneration withheld, okay, to act as a financial disincentive, to disincentivize the occurrence of these hacks with those financial penalties in place. Now, there's a lot of conjecture as to is this a sustainable model? Is this the best way to go about it? I've actually expressed my thoughts on this as well. I've actually put in a submission, a public submission, a consultation paper to the IPA only a number of months ago, outlining my recommendations for an improved risk adjustment model, particularly for infections in a cancer case mix where we know that these risks for infectious hacks are so high compared to a non-cancer case mix. So from a health services research perspective, we want to ensure that the risk adjustment models that are in place are sustainable and are equitable right across the board. So I've actually put those, I've put that to the IPA recently. So in very, very simple layman's terms, the more hacks that get reported, the less funding you get. It's really as simple as that. So with this study, I looked at calculating the positive predicted value of infectious hacks in a cancer case mix, more locally at the Peter MacCallum. So how I did that was I said, right, I want to identify all of my infection hack coded episodes at the Peter Mac over a 2-year time span, in which case there were 420 of them. And then I retrospectively went back through each of those 420 records and I applied some consensus surveillance definitions for each discrete infection I was interested in, okay? And I said, right, is this an actual infection according to surveillance definition? Yes, is it not? So on and so forth. So what I came to, of the 420 hack-coded episodes, only 161 actually satisfied surveillance definitions for those discrete infections, which comes to an overall PVV of 38%, which isn't very high, for obvious reasons. Now, I then stratify that by underlying type of infection. So all the ones that I actually evaluated, take home, obviously, for this is the MDRO infections had an overall PPV of 46%, so a bit higher than the overall pooled average. What I found particularly fascinating was pneumonia, hospital-acquired pneumonia, was 13% PPV, which was, and there was a myriad of reasons for why that was the case, according to my chart review. But yeah, there's clearly quite a lot of variability in terms of how well infections get coded from a hack perspective in a high-risk cancer setting. Now, to drive that message, particularly for what this means in the broader sense, from a health policy perspective and also from a health economics perspective, is in terms of, well, what does that mean for hospital remuneration? So what I did is the second part of this analysis is that for those discordantly coded episodes, where we have a code, but it does not marry with surveillance definitions, what does that translate to in lost funding opportunity? So I actually simulated the IPA's negative funding adjustment algorithm on my data. And I said, right, how much would we theoretically lose? This is all theoretical. This is pre-policy period, of course. So on average, we would lose about $1,100 per episode in withheld hospital remuneration every time a discordant coded infection is reported. Now that might not sound like a lot, but I think over this 2-year time span, it was about $900,000. It was a significant amount of potential withheld hospital remuneration. Now for the MDROs, we're seeing a very similar estimate at about $1,100 as well. So take home here is that there are some significant financial implications for discordant coding. And this is really why good coding matters. We need to ensure that we have robust documentation in place, but also that we have robust clinical coding practices in place to ensure that we are getting that accuracy. Now I'm going to finish on a more of a positive spin here, some opportunities for the role of admin data for infection surveillance, but also for HSR. So this is one of the hallmark studies of my PhD, if not the hallmark study, I think, is quite a large data linkage work. And I know this has been talked about in previous presentations and yesterday as well, is the value of data linkage. And I really, really want to go down this path, and I'm doing that right now as part of my PhD. So what I'm doing here with this particular study is the research question is, how can I optimize existing surveillance methods for detection of invasive fungal infection, for CMV disease, but also for Staph aureus bacteremia in patients or in high-risk patients with hematological malignancy. Now, how I've gone about doing this so far is that I've collected a broad range of different data from different clinical information systems across both the Peter MacCallum but also across the Royal Melbourne over a 7-year time span. Now, what I've done here is that, as per my schematic, I've collected all of the ICD-10 codes across those 2 hospitals, all the ACHI codes, I've collected microbiology data, I've collected all the serology, all the histology, all the clinical chemistry, all the antimicrobial dispensing, and of course, the gold standard diagnosis for each of those 3 discrete infections. And after collecting all that, which was it was an 18-month slog, it was actually quite a long time to get it all in place, the governance and the ethics and all that sort of thing. But once I got it, I then worked with BioGrid, based at the Royal Melbourne, who facilitated the linkage of all of those data into a huge linked data set. Now, what I'm doing with this data set is I want to use and this is all pre-EMR data, which will become important in a moment, link all these pre-EMR data to determine the combination of case finding indicators or data elements, so which of these purple circles gives us the greatest improvement to classification performance of infection. Because I think one of the important steps, one of the earliest steps in order to make that transition from manual to electronic surveillance is determining which of these data, which we routinely collect for a broad range of reasons, which of those actually gives us the best bang for our buck in terms of sensitivity, in terms of specificity, et cetera, et cetera. And once they're identified, then we can massage that algorithm and then put that in, trial that in real time kind of thing. So really what the aim here is to identify what is that most optimal linked data algorithm. So which combination of those case finding indicators does give us high sensitivity and PPV. And if indeed, and this is still a work in progress, I'm actually doing this now, so there's a lot of results coming through, but if indeed ICD-10 actually value adds to classification performance, once again acknowledging that time lag will become important. Well, if it doesn't, so if ICD-10 does not value add, I can actually then test that algorithm, that combination of data in real time. So I can apply that same algorithm to EMR data in real time and say, do we yield the same results for case ascertainment? Are we still getting high sensitivity in PPV? If so, we could be onto something here. Okay, we could actually be onto some real-time surveillance system that leverages all these different types of data, which would therefore be somewhat of a prospective surveillance system. Now, on the flip side, if indeed from my analysis that the codes, for whatever reason, appear to be actually improving sensitivity, then once again, going back to that earlier slide I had before, well, maybe we can still harness the value of the codes and do somewhat of a retrospective modeling kind of thing. So we retrospectively predict infection into the future using the codes, of course. So to finish off, future directions. So administrative coding data, or ACD, are a very feasible source of information to measure infection rates and health service delivery. I just want to make that quite clear because it is a very useful source of information. But efforts are needed to safeguard coding quality. Now we can do this is all hypothetical, but we can do this through regular liaison between the clinical coder, but also infection prevention staff to actually prevent any discordance, because it's effectively like 2 different languages. Clinical coders must adhere to Australian coding standards, whereas medical staff and infection prevention staff will adhere to surveillance definitions and clinical definitions. And often those 2 don't meet, and that's a very important point to make. So maybe bridging that gap could be a way forward. Harmonizing clinical definitions with those Australian coding standards, as I mentioned, and also data linkage. I mean, hopefully I've demonstrated in this talk that there is some value in linked data, and with data linkage, the world's your oyster, because you can do so much with it. You can identify different patterns in data and different trends and so on and so forth. But I think probably one of the most important take-home messages from my talk is that if you're thinking about using ICD-10 in your surveillance system, where be it for MDRO infections or whatever it might be, you need to fully understand what is the aim and scope of your surveillance system. Is it something retrospective? Is it something more prospective? And you need to just take into consideration some of those disadvantages that I alluded to earlier. So I'll finish up there. Thank you very much for your time, and also thanks for the opportunity to present. So yeah, I'll leave it there. Thank you.
Thanks, Jake. Amazing presentation. I always laugh when Jake talks, because you know how when you watch a talk later you speed it up to like 1.5 to get through it quicker. Well, Jake, you need to actually slow it down.
All right.
No, it was great, Jake. I've got a really practical question, actually. So if someone online who is watching today has decided, well, that's pretty cool, and I would like to go and do that in my hospital because I would like to look at, surveillance, who do they speak to? And what are the skill sets of people that they need to help them with such a project?
I think you need to speak to a whole broad range of stakeholders. So the first person would be someone like Health Information Services, who can actually guide you in determining what are the most appropriate metrics from a coding sense that you need to actually implement into a surveillance system, be it certain coding definitions or any other sort of patient demographic information, which is very important. The second person to go to, particularly from an infection setting, is to actually go to the infection prevention staff and actually understand, well, how how do they interpret what an infection is from a surveillance perspective, and then how does that marry with what a coding definition would be. But also just to speak more broadly with all other different data custodians, be it from a pharmacy point of view, be it from a pathology point of view, and anecdotally, I've done that over the last couple of years, and it is quite an arduous process, because you need to get stakeholder or data custodian approvals. You need to get them on board with the project, and if you want to develop a surveillance system, they need to be privy to what you want to do and what you want to achieve from that surveillance system. So I think that's probably the biggest message there, is to just speak to a whole broad range of different custodians.
And if you're just going to do a single project, so maybe someone might want to look at pneumonia appropriateness and outcomes. I think what we've heard is you actually need to, the health information coders are really excellent. So they do actually have a highly structured process and are very, very knowledgeable, and they are going to be absolutely integrally important to help you. And then often some of the larger principal referral hospitals obviously have business intelligence units that can also help you. It just becomes a lot harder when you go out. And so the other way to get the data is not so much from your own individual hospital, but to look at a statewide data set.
Yeah.
So these are data sets like the VAED data set in Victoria, and there's also comparable large data sets from all hospitals. Each of those will actually have a data governance approach where you need to specifically request what you want, and they generally have a structured approach, and you will be given a bit of data or a proportion of the data as long as you actually meet all the requirements, and it's quite a strict process, obviously, for data safety and information.
I think that on that point too, Kaz, is that I've had experience with collecting admin data from a state level as well. So I've done some data linkage work right across Victoria, linking the VAD with other different administrative and registry databases. And that's another really untapped opportunity for ICD-10, particularly for an infection surveillance perspective. It actually affords that opportunity between population-based surveillance, be it across a state or territory, or be it more locally at a hospital level. Because at the end of the day, the coding data that would be collected in the VAD, for argument's sake, actually comes from the hospitals, and you can actually use that data from both levels, from both perspectives, to measure quality improvement, to measure infection rates, and so on and so forth. So I think that's really an untapped opportunity, I think, for ICD-10, particularly in the cancer setting.
Thanks, Jake. I'm just mindful of the time this morning, so we might thank Jake, and we'll Brian, who's another one of our PhD fellows. He's with NCAS in his third year. He's actually a veterinarian who started veterinary school at Washington State Uni after working several years as an engineer and a consultant for Microsoft and other technology companies. So you can see why he's talking about what he is. And while he attended veterinary school, Brian joined the Association for Veterinary Informatics and began to research the use of natural language processing to study veterinary medical records. And he's currently applying this to VetCompass Australia, which is one of the medical prescribing software systems, veterinary prescribing software systems, to better understand antimicrobial usage patterns in veterinary medicine to aid in AMS. So welcome, Brian.
Thanks, Karin. Can everyone hear me all right? First of all, I'm guessing not.
Yeah, all good, Brian.
Oh, okay, good. So I'll just dive in. I'm guessing, how much time do I have? I've got about, does it look like about 15 minutes or?
5 minutes, Brian.
What's that?
Minutes, Brian? 20 minutes?
Okay, 20 minutes. All right, well, I'll just dive in then. This project is focused on extracting data out of VetCompass, like what Karin was just talking about. A little bit more about this is sort of what the project has been and sort of where it's going is we're looking at antimicrobial resistance and antimicrobial stewardship on the veterinary side, because, you know, as everyone's aware, that antimicrobial resistance is an emerging global crisis. Fewer people maybe are aware of veterinarians contributing to antimicrobial resistance, so I like to have this slide always in there just to show how close, you know, animals are with people at all times, and then also that antimicrobial stewardship programs have been well, or seem to be demonstrating pretty well in the human hospital setting as being a good way to combat this. So that's what we're doing with this project, is trying to support these antimicrobial stewardship programs that we're involved with, using data from a very large repository, VetCompass Australia. Over 180 clinics are submitting data to this repository. There's over 15 million clinical records, 1.3 billion tokens, which you'll see later means that there's that's how many word fragments there are, which is really important for machine learning because we want lots of data to support our algorithms. And this is what I'm talking about today is sort of in follow-up to previous studies that we've been doing, exploring the antimicrobials that are used in consults, where we created some rules-based algorithms to figure out which antimicrobials are being given at a consult level. We use natural language processing to do our, is just a broad term that we use to describe what we're doing when we're pulling this data out. It's basically a crossover from computer science and AI. I'm concerned with interacting with computers and human languages. There's various approaches. Again, machine learning is the one that gets talked about a lot, and which sort of crosses over with deep learning and neural networks. But there's also rules-based systems play a really heavy role. And so Karin, who I don't believe is here, would really want to make sure that I express how important rules are in these systems, even though, you know, we hope AI and neural networks can solve our problems someday. You know, rules have a good place in all this. But what NLP lets us do in these cases is it lets us process really large amounts of data. You know, it's just not feasible to label that many records when we start to get into the millions. So we've been experimenting with ways to be as efficient as possible with these. So again, this is from the first study that we did, where and this is the same sample size we're using, which is it's about 4.4 million records between 2013 and 2017. Where we found that overall with cats, we have about the antimicrobials, that's out of 1,000. So about 11% of cats and about 15% of dogs are getting, per consult that they have, are getting antimicrobials. And we extract that data. However, and we were able to look at topical versus systemic medications and how they were being given across the consults. However, we were left there. You know, we didn't know why they were given, so it's really hard to talk about appropriateness of usage and support these programs without diving in there. So that's where the focus of this talk is how can we figure out what's given? And so to give you an example of what the records look like on the veterinary side, you know, here's a record where the drug cefalexin was given, which is a 3rd degree cephalosporin, a critically important antimicrobial, and it was being given for ear disorder. But if you read this, you know, it's not very clear. It doesn't say ear anywhere on there, I believe. You know, it's not able to extract that ear disorder was the reason this medication was given. So we want to make sure we're able to extract those things out of medical records so we can appropriately label those. And that was the purpose of the preliminary study. And so we wanted to create a classifier that could then classify the reason for administration of antimicrobial agent, given the context of that antimicrobial. The other thing that we came across that we were experimenting with our methods is this idea of domain adaptation, which is important when training models because not all things are similar. We were focused on different antimicrobials because if you create a classifier that's really good at saying ear disorders are good for cefalexin, it might not be very good at saying, you know, metronidazole was given for diarrhea or something. So we need to make sure that it works in these different contexts. And that's what we were really focused on our models to make sure they generalize really well across these things. And also annotating is how we generally get these things going. which is you supply your models with some annotations and you train it to use those annotations to annotate the rest. But this is a very expensive process. So we were focused on minimizing the effort required to make a generalizable model so it could label all the different diseases with all the antimicrobials without losing accuracy. The labels that we used, a lot of people might be familiar with SNOMED. Fewer people are probably familiar with Venom, which is veterinary nomenclature. But this does map to SNOMED codes, but they're veterinary specific. So you can still leverage all the tools you have around SNOMED if you are using Venom codes. And the labels that we had to do our training, as well as to do our experiments to test these domain adaptation things, was about 5,000 records that were labeled for another project looking at self-efficacy done by Laura Hardefelt. And so we use those labels to sort of bootstrap the rest of our methods. We also labeled an additional set of records using amoxicillin clavulanate and cephalexin to use as our test to see how well they would work on those two antibiotics. When we compared our annotations, so I labeled a subset of data with Laura, because that's always a big part of machine learning, is you want to make sure your labels are accurate. And humans have a high level of error. Or if you get two veterinarians in the same room, same thing as two human doctors in the room, like they'll typically disagree on a lot. And so we compare annotations, get about a 0.78 or a 0.78 Cohen's kappa, which is about a 80% raw agreement score of how often we agreed on the right reason for those antimicrobial administrations. So I just want to make sure you're aware of those things when we dive into it, because that gives a bit of context with the accuracy, because you can't really get above that glass ceiling of your annotations, which is roughly 80% in this case. And so again, the antimicrobials we were looking at were cephalexin, cephalexin, amoxicillin, clavulanate. And this is sort of the distribution of diseases that we had between those different medications. And in different slides, we refer to them as source domain, which is cephalexin, and target Y and target Z or Z for amoxicillin, clavulanate, and cephalexin, and the rough distributions of those diseases. And so our initial solution was, well, we'll just train a neural classifier, see how it goes. We used a really popular one called BERT. And we also used some baselines, long LSTM, without pre-training it, which just means that we didn't give it any context to know anything. We just took a vanilla neural network and started testing things to see, where things were at. A little bit more about BERT is basically the way that BERT works is it trains by looking at all the data on the internet and then does a matching game. So to try and figure out if the next sentence comes after the previous sentence, and then that way you can just use any data to do that, because you can take as many sentences as you want. You can create an algorithm to create as much training data as you want. So that's why that's important. It gives it a really good understanding of our language. The other thing it does is it randomly pulls out a word and then has it try to guess what word should go there, and then it has the answer already. So it knows that in this example, we say clients report the blank was extremely pruritic, and the answer is patient. It would pull that out and then train the model to just pick patient. So we have this model that understands human language really well, and then we go on to train it to do other things. And it's a lot easier to train with a lot less data if you already have a model that understands language. So when in this we talk about like these representations of text, we call them embeddings, and it's like, well, what are these embeddings? And they're basically really large representations of numbers for text. So like when we have this word cephalexin, that could be broken up into different fragments, and sometimes they're entire words like the or something. And each one of those fragments has a really large vectors, 3 by 768 exact. So that's like basically 2,034 different numbers that can be combined that only these neural networks understand to represent not just what word is there, but what that word means in the context that it's given. So that can be really powerful, and it's lots of data, but neural networks, they like lots of data, so I like to use Cookie Monster as representation because lots of data means better results, essentially happier models. So for our process, what we did is we used some methods from another model called Clinical BERT, which takes BERT, which is just trained off data on the internet, and then they train it on another data set of emergency clinical notes. So they take a MIMIC-3 data set is what it's called, and that's what we use sort of as the base of our model. So it has not just an understanding of human language, but it has an understanding of clinical text as well, which is more similar to veterinary text than just Wikipedia articles, which BERT is trained on. So our again, our proposed solution, we'll create what we call VetBERT, which is we take those same steps of making clinical BERT, where they do the process where you pick words and remove them, and we do it with the veterinary data set as well. So that way it kind of learns what veterinary medical records look like. And then again, our baselines don't do this, and that's what it is. It's just it just uses the traditional neural network patterns where it looks over the data set and figures out how to classify them. So just seeing how well using VetBERT versus vanilla BERT or even our vanilla LSTM, you can see there's a pretty big performance boost, especially when we're just looking at our source domain. And we're hitting that level of 80%, which is sort of the raw agreement score of the annotators. Getting above that is kind of difficult, and so we did really well with VetBERT. However, when we transfer over to looking at records that we're giving amoxicillin clavulanate, which is our target Z, we get a significant drop. And the top chart is showing the 5,000 annotations that we have, but that takes well over 40 hours to do. And then so our next step was, well, what could we do if we only had 2 hours of annotations? And that's where we just labeled, we reasonably assessed that, about 250 labels could be done within 2 hours. So that's what these next assessments are based on. So we look at the difference between BERT versus VetBERT when it only has 250 labels, and we see that there's a pretty significant degradation in performance. And so to sort of address this, we noticed that it's dropping a lot, with those changes. And so we came up with some methods to sort of address those. Here's a lot of the methods. I'll kind of fly over that because it's not really the focus on the talk is so much the methods, just the general principles on how we're using these things. And so, we did some different things to address the problem of instance selection, to address the problem of domain adaptation through using what we're calling instance selection. So if we're only going to label 2 hours of data, we want to make the most use of that 2 hours when we're labeling that data. So the general principle that we're thinking of when we do this is that if we have 2 different domains and they're separate, and let's just for a second, we'll call them dogs, cats, and lizards, and we'll just call these the different domains we're looking at. They have a lot of features that are similar. They have a lot of features that are just exclusive to them. And so if we're looking for something that is going to work on all of these, like whether or not it's a dog or a cat or a lizard, we can't talk about, their 3-chambered hearts, because that's specific for lizards, or barking for dogs, or meows for cats. The only thing that have been in common that I came up with was tails, right? And so those are the instances we want, are the instances that have tails as part of their features. And we're not just, so we ignore all the rest. And that's what instance selection is doing, is we're trying to find the things that have features that are most in common with all the other domains. And so again, here's what they are. These are antibiotics, and what we're looking for are those shared features. And so we train a model to basically pick out instances that have the most shared features between all of them, and ignores the ones that don't have those shared features. And in reality, it looks more like this because they're quite similar. They're not very different than each other because they're antibiotics and things. They're a little bit more similar than dogs and lizards, for example. So we had different methods that we borrowed for that, and we were able to start. I'll just jump over some of these with how we were using our methods, and just sort of look at the results that we had. The most important thing to look at on these results is looking at, again, on the far right, we have the difference in performance for our amoxicillin clavulanate domain. So initially, we were only getting about a 60% accuracy, versus when we do our other methods, we were able to boost it closer to 70%. And so that's with just 2 hours of labels. because our performance was pretty good with the full set. It was more just with the 2 hours of labels that we want to get the most out of. So there's definitely room for improvement on doing the instance selection, but those results are pretty good just in general, for being distant from the accuracy. So again, this is just what it is without our methods. And then before, we're able to boost up the accuracy across all the domains and make them more similar. So, the findings were that we had VetBERT and it worked relatively well without any modifications, but pre-selecting could improve those with much less data, which was good for us because, we're a small group and Laura's really generous with her time and, I can spend as much time as I can, but we don't have, 40 hours for every different task we want to do to train these models on. And then the key message, again, coming back to Cookie Monster is counterintuitively, you can actually get better performance with less data if you're picky about the data that you select for your models with this. Like if you just put a little bit of time to pick which instances, because I think that's probably might be the thing that's relevant for anybody doing research in these areas, is that it's really important to look at methods that will help you reduce the amount of data you need to train your models and that they generalize across the different subdomains you might be dealing with in your experiments. But coming back to focus it back on antimicrobial stewardship, we were able to look at the performance of the classifier, and it surpasses raw agreement score on the source domain, but it varies substantially based on those antimicrobials that are given. So it's really important to assess accuracy of models on different source domains while you're dealing with it, just because you end up with biased data otherwise. So the next slides are some of the early results that we have using these models and these methods to start looking at the reasons why antimicrobials are given. And they're currently not published, and so the results are not finalized, but I thought they were good to include for this presentation. Otherwise, it's a little bit too machine learning. So going into that, so we were able to look at sort of the top 3 diagnoses by ingredients and just look at the amounts that were given. Unclear records are actually records that are not clear when you read the record. It wasn't just that the algorithm couldn't figure it out, but even when humans look at it, we couldn't figure out what it is. So not surprisingly, there's a lot of unclear records where we look at the records and we just can't figure it out. It wasn't, I forget the exact number that the total record looks for, but some of them are more so than others, and it could be due to previous consults saying the reason that the antimicrobial was given, and then next consult just not mentioning why it was given. I mean, those results really need to be further analyzed. But it does sort of fall in line with what we know generally, like cephalexin is given oftentimes for skin disorders, metronidazole, again, given for diarrhea, which we just classified as enteropathies for our disease syndromes. And different results that we see there, along with their rating system. And as we're trying to use this to sort of help us promote antimicrobial stewardship programs, we're also looking at the appropriate doses for them, which I'll get into the next slide here. Just really quick on this one, we just go into what the topical medications were and the reasons that they were given. We're not actually really super interested in this, but we put a lot of effort into getting this stuff out, so I thought I would at least share the presentations. Most topical things are just given for ear disorders, eye disorders, and skin disorders in general for these things. And then sort of what we were able to do, though, is we're able to look at the differences between administrations for human practices, or sorry, general practices and emergency practices. And we had percentages, but the results for emergency practices, there's just too few of them at this stage to really make good assumptions or to make good analysis out of our results on those. So we're not really looking to emergency practice, and we're just looking at general practices primarily for the data. But what I want to make sure to show too is this one is based on, these are the dose administrations these are the doses that they were given for a different disease, and we're able to extract sort of the dose of medication that they were given at the consult. And these dotted lines represent like what the recommended guidelines are with the vet antibiotics or from NCAS that we've released and that are published online, just to sort of show the differences in what's actually being given inside the clinic versus what's recommended in the literature. on this, I just want to point out that there are some discrepancies in what's given by drugs like doxycycline and cephalexin especially. And the reason that is sort of what we're seeing is most likely due to just differences in what's in the drug label and then what's actually recommended inside the papers that we can find. The labels do have to pass APVMA guidelines, but the drug companies don't necessarily have to share those guidelines, or not the guidelines, but share the studies that support their efficacy. So there's some work that needs to be done in that area potentially. Laura Hartfeld's done a study on that a couple of years ago, just looking at those discrepancies. But it definitely is shown here when we look at what's actually being used in practice as well. So again, our preliminary findings is that we are able to automate the evaluation of appropriateness of usage. The methods exceed expert inter-annotator agreement on accuracy in many cases. But the records need to include the weight, reason, and amount of medication in order to determine these things. So we're not able to get it out of every record, but we can get them out of a lot of the records. But if we don't have things necessary to make those calculations, then even if a human can't do it, we can't teach a machine to do it, basically. And then also, obviously, the veterinarians use a wide variety of doses that we demonstrate in that data there too. And early, we're suspecting it's probably due to differences in drug labels and supporting literature, but then also tablet sizes, which is probably a much bigger issue in veterinary medicine than it is in human medicine, just due to the various sizes of patients that we see. So I wanted to thank everyone really quick, all my supervisors and co-authors on these studies, James and Laura and Tim and Karin, as well as some collaborators that helped us with it. If you're interested in taking a punt or looking at it, the code, there's a GitHub repo that I have the code publicly available, so you can test the models out yourself, or and then also the references here. So with that, I'll open it up to questions. Thank you.
Thanks very much, Brian. So I open up for questions from the audience now, but I'll ask my first one. So the approach we've taken in hospitals, Brian, is essentially to make indications a mandatory field for doctors. I mean, most of us are still dealing with free text, but at least it's in the space where you need to find it. And in our GP Maps program, we've also, one of the actual interventions to improve the quality is actually to really nudge the GPs to do an indication of the time, because I'm not sure if you're aware in software prescribing programs in general practice, the compliance of actually ensuring the indication at the time of the script is uncommon, but there will be an indication somewhere else in the record. So if you actually enforced an indication at the time of prescription, do you think that would make your life easier?
Yeah, I mean, it would definitely make everyone's lives easier, I think. Because I think even, I think a big problem is that for a long time we weren't looking at these things, and records were just used for insurance providers in the US a lot of times to inform like what they're paying for, and the details that are important for antimicrobial stewardship programs are it's simply not in the data. I think in our data we only had about 33% of the records that actually had that data present, so that that our algorithms could actually make a decision. And I don't know what those numbers are like in human practice, but I'm guessing it's probably similar, if not lower, based on what you're saying.
So in terms of moving to prime time with natural language processing, how far off are we?
I think we're already ready, like, for data extraction, because again, like we were showing, like it's if we put the time and effort into making a system work, I mean, a lot of these algorithms and models they're not off the shelf, but they're implementable, like at a level that's proven to be at par or more. I think the bigger problem we're facing now is just working with the clinicians to implement them in an effective way. And so I think it's critical that clinicians get more involved in this area, just to help promote it more and to just start doing clinically relevant things with these models, instead of the other way, which a lot of times it goes, which is the computer scientists come in and say, how can we help? And clinicians are so busy they don't have time to really talk to them.
I think that's a general point with any of the health services research, is that we need to be working alongside the informaticists and the health economists and the social scientists so that we can make sure that what we're doing is actually appropriate for implementation down the track. Are there any, oh, here we go. So Jay Gomboso, could this work be extended to assess antimicrobial usage in poultry, pigs and cattle?
Yeah, I mean, absolutely. Obviously, the data that they have is different, and usually it's like one person treating lots of animals when you go to those industries. So they're quite different, but the same methods could be used, and arguably it would be easier because you don't have to deal with such a high variety of individual clinician preferences on how to write records.
Any other questions from the audience? James, did you want to make any comment? James Gilkison?
Thanks, Kaz. I think Brian's covered off very well on a lot of the issues that we're facing. Just on the question around, you know, applying it to production animals, the Vet Compass database the data set that we're using is strictly companion animals. So it's basically dogs and cats with a few pet birds and other exotic animals thrown in. But yeah, we would love to go and be able to look at these sort of records from other production animals, but that's the next step, I guess. You know, got a proof of concept. I think part of the things, one of the things that I think you've identified is around socialising the benefit for this. You know, I think we need to be better at communicating what the benefits are. We're all interested in antimicrobial stewardship. And I think when we speak amongst ourselves, all of the reasons for doing these things are immediately apparent. But I think we need to start talking to people outside of our group as well, because I think sometimes in practice, the idea of the data being used as a weapon against the practitioner is some practices have issues with that, and other practices, you know, as Joanne was saying. So I think getting out and about and you know, really promoting the engagement with this as a benefit, you know, and the benefits of engagement, I think are really important for us.
Thanks, James. Any other last minute questions? Otherwise, we'll finish this session up. As you know, it will be posted pretty quickly onto the NCAS website. I really would like to thank all our speakers today. So obviously it's interesting and complex work, requires expertise, but once again, we actually need to be working side by side to pull together to utilise data in an effective way. So many thanks to everyone, and enjoy the rest of the webinar series. And once again, a shout out and thank you to Arjun, who is working very hard to make sure that this event is pulled off.
I was just going to speak really quick to Jay, who asked a question in chat, like about could this work be extended to assess, or wait, is there a Vet Compass equivalent for production animals? I think was the follow-up, and the answer at this stage, I believe, is no. But James would be able to speak more to, James Gilkerson would be able to speak more to what the state of the data is in production medicine than I would.
I think, Brian, in the interest of time, the short answer is no, but we'd like there to be.
All right. Thanks, everyone. Go and enjoy the beautiful day, and hope that you catch up with the other sessions, and I'll sign off. Happy Antimicrobial Awareness Week.
Thanks, everyone. Bye.
Thank you.